Good morning. It's 7:30 and it's time to start our grand rounds. Before I introduce this morning's grand round speakers, I have two quick announcements. Number one, some of us, that includes me, are not receiving emails, the weekly announcements on grand rounds, which Delia sends every week. So if you are one of those who are not receiving her announcements regarding grand rounds, please let her know so she can look into it and see why we are not receiving the weekly grand round announcements. Number two, I'm getting very few evaluations after the grand rounds presentation. So Delia sends the evaluation forms, the survey monkey form after the grand rounds. Please complete those evaluations. Those are very important for me to give feedback to the speakers after their presentation. So with that, I'm going to introduce this morning's grand round speaker. Professor Jim Brookshire is a cranial remodeling specialist and faculty in the Department of Neurosurgery at the University of Texas Long School of Medicine here in San Antonio. Prior to Itasca, Professor Brookshire was at Texas Children's Hospital in Houston, where he built one of the largest cranial remodeling clinics in the world and instructed on cranial deformities at Baylor College of Medicine. In 2017, he was published in 100th Year Orthotics and Prosthetics magazine for his cranial remodeling treatment algorithm, which is now considered a standard for treatment worldwide. In 2018, he joined the Department of Neurosurgery here at Itasca, where he is continuously researching, instructing, and publishing to optimize outcomes for cranial remodeling treatment. So Professor Brookshire, thank you very much for accepting our invitation, and the floor is yours.
Thank you very much, and thank you for having me present today.
Are you able to advance the slide or? Yeah, I see your first slide.
Okay.
You were able to advance just a few minutes ago. So.
All right. Let's stop sharing and go back to sharing real quick.
That's fine. That's fine.
Well, I don't know what to tell you. There we go.
Yeah, you can. Yeah.
Okay. When I first started here at UTESCA, what we did is we took a look at the population, and we wanted to see what the prevalence of cranial remolding could work for in the community and how prevalent it was. And what we came across was estimated 3.1 under 24 months, based on a population of 1.1 or 1.5 million in Bexar, Como, and Medina County. We came across 46,870 under the age of 24 months. It's estimated that 1.5 will have a severe deformity. That comes out to 703. For infants under the age of 6 months, 10 to 15% will be diagnosed with mild to moderate head-shaped deformity. And as a result, approximately half will require cranial remolding treatment, which is 2,930. 1 in 2,500 births diagnosed with craniosynostosis. That does not count the patients that we have that come internationally. For a potential of 3,652 in these counties that could use cranial remolding. Like I said, that does not include all the patients that come from other states or from counties with outside of our region here, but it just goes to show you that it's very prevalent and we only treat a small percentage of those patients. So how do the sutures grow? If you look at the metopic suture, um, it's going to fuse at about 2 months of age, and the sagittal about 22 months of age, the coronal 24 months of age, the lambdoid at 26 months of age, and final bony fusion really isn't completed until mid-childhood. However, there is so much variance in here that there's no, steadfast, really concrete answer. I know we always check the fontanelle, but I've seen the fontanelle close as early as 3 months and be totally normal, even though you feel like it's completely closed. A lot of times there's just a small sliver that remains open until adulthood. But primarily, these are just the standards that we go by, and as you know, for fusion, and they're real predictable in their times. The way the sutures grow, you can see the metopic, it grows laterally. The coronals grow anterior and posterior to provide elongation for the forehead. The sagittal grows laterally, and the lambdoid sutures grow anterior and posteriorly so that they provide um, length for the posterior aspect of the head. Now, very important here, at 1 to 3 months of age, these babies are growing at 20 millimeters per month. At 3 to 6 months of age, 10 millimeters a month, 6 to 9, 5 millimeters a month, and 9 to 12 months, they're growing 3 to 4 millimeters a month. We really typically need about 15 to 30 millimeters to correct most head shapes, being from moderate to severe. And the optimal age at that point, if you look at the growth chart here, is that we're looking to get our correction at at least to be starting at 4 to 6 months of age, as a result, being able to achieve that 15 to 30 millimeters of growth that we need to correct those head shapes. Cranial remolding is nothing new. It's spanned for thousands of years in Egyptian, Mayan, Aztec, Peruvian cultures. They've been doing this for thousands of years, and it's been a cultural identity, mainly to shape the heads and to make them elongated. You can see here, this is done in the 1930s. It's where this African tribe would actually, this is kind of the rite of passage for the babies to go through the binding. They would use giraffe tail and zebra skin to be able to bind that head up. But you can see the mom here, you can see how her head was manipulated. There's no correlation between head shape and development or function. And we know that just by looking at the pyramids and things like that. We still don't know how these were completely constructed, but they've been binding heads for thousands of years. So there's nothing that shows that there's any correlation there between development and head shape. But the duration typically is about 6 to 10 months of age, and it would last throughout childhood, all the way through adulthood, and be a permanent shape from then on out. So what causes deformational plagiocephaly? We know that sleeping position absolutely is a primary cause. Premature births in the NICU because of the softened, thin bone, laying in one position if they are not rotated and turned normally, what will happen is you'll get that flattening. Torticollis, intrauterine positioning is a big one. Cervical abnormalities, birth trauma, sustained supine position. These are all primary players within the cause of deformational plagiocephaly. So we noticed a lot of us were raised on our backs, and often you say, well, why in the world is it happening so often now? And the reason why is because around 1993, the American Pediatric Association came out and said, hey, listen, if we put these babies on their backs, it's been shown that we can reduce sudden infant death syndrome by around 50%. And so as a result, from that point on, you can see the prevalence of head-shaped deformities start to rise. Okay, and that's what we see today, is it continues to rise just as a result of people being more aware of it. There's a lot of campaigns that talk about tummy time and back is best and back to sleep. But it's better than the alternative, right? So this is something that's here to stay. You're going to see it in your clinics with your patients, and it's something that will benefit you to know a little bit more about. So how do we go about evaluating them? So first of all, we're going to see a lot of the patients that come into my practice are going to present with a tilted head, a tightness to one side, shoulder coming up close to the body. There's a lot of different ways that this presents, but it's for torticollis, it's quite common to see that real lateral head tilt to where the head and neck are tilting to one side. Typically, this flattening is going to be on the opposite side of where the tightening of the sternocleidomastoid resulting is existing from. We're looking at, when we take measurements, what we're doing is we're taking a circumference. If you're doing this manually in your office, what we're looking for is right at or slightly above the glabella. We basically want to take the widest and longest points and take a tape measure and just put that measurement, make sure the head is horizontal to the floor, and record that measurement down. For cranial width and length, what we'd like to use is calipers. And once again, keep the head horizontal to the floor. We're going cranial width at the widest dimension, cranial length at the longest position. And then what we do is we take the length and divide it by the width, or I'm sorry, width divided by the length, multiply it by 100, and that's going to give us our cephalic index. And what that means is the head is whatever percentage as wide as it is long. Normal is 78%. So what does that mean? Well, for cephalic index, it's a disproportionate ratio. And so you'll notice here to the right, which is moving towards what's called a brachycephalic head, which means short head. And to the left is a dolichocephalic, which means long and narrow. Okay, so 78 is the mean. As you move one deviation, you go up to 84. As you move two deviations, you go up to 92. That's for a male 6 to 12 months. But you can see through this chart here, females, nearly the same. As you move to the right, the head is getting wider. As you move to the left, the head is getting more narrow. This is a way for us to track, where they sit within the severity of deformity for disproportionate. Now, for plagiocephaly, what it is we're looking for diagonal measurements here. We'll go 30 degrees off midline from the anterior location at 30 degrees to the posterior location at negative 30 degrees. We come to the opposite side. We measure from the right, negative 30 degrees, to the posterior, positive 40 or 30 degrees. And what we do is take the difference between those two linear measurements and we record it. And what we found is that within normal limits, any head under 6 millimeters will fall within that category. A mild deformity is 6 to 9 millimeters. Moderate is 9 to 14 millimeters, and severe is anything over 14 millimeters. We begin to treat at 9 to 14 millimeters and over 14 millimeters for those particular deformities specific to plagiocephaly. How do we record it here? We have what's called a star scanner. It's a class 2 laser. What we do is we lay them down into this little bed here with a stocking, which is actually a reflector. And what happens is it's almost like a copy machine. It passes over the head and gives us a 3-dimensional image. Okay. Then what we are able to do is we are able to produce an image and an outcome that shows us exactly what the measurements for that scan are. And then we're, as we work through the treatment or do follow-ups, if we're working conservatively, what we'll do is we will be able to overlay these scans, and what it provides is a way for us to look and see, is the head correcting? Is it getting worse? What's going on with the head shape? And this is what it would look like. This is the output from the scan. So looking back, what are these deformities? Um, Plagiocephaly is it's a Greek term meaning plagios, which is oblique. Kephale is head, and that's where you have a flattened, two flattened corners. Not always, but most of the time, flattened on the right, flattened on the front left in this case, and bossed on the front right and posterior left. It can be right or left side, but just for this case, I'm just showing you how it looks like the head is going to the right, even though the nose is lined up anteriorly. That's an oblique angle, and that's what plagiocephaly presents like. Brachycephaly, meaning short head, and you can see here the distance behind the ears is short. We have very little occipital protuberance there, and we have most likely they're going to have a vaulted head to where it's quite tall and quite a bit longer in the front, just as a result of the disproportion being off anterior and posteriorly. Scaphocephaly, what we have here is a narrow, elongated head. Scaphe meaning boat, kephale meaning head. This is something that is more prevalent in craniosynostosis. So deformational plagiocephaly, the evidence of intrauterine constraint, this is where it all starts as a result of being up against one side or the other. Um, It may go unnoticed in neonatal period, but that's where the distortion begins. And as a result of that, once they're born, if torticollis is there, what happens is it's following that growth pattern. Or if there's extreme flatness on one corner, what's happening is that they are favoring that side as a result of it just being flatter. And so it just continues to grow along the surface and presenting more deformed as time goes on. And what you're going to have is you're going to have the ipsilateral anterior ear shift. The ear shift cannot be corrected with helmeting, just so you know that. It will eventually, as the face grows in time, 2, 3, 4, 5 years of age, as that face begins to grow and the jaw begins to grow, typically as a result of it being connected by the zygomatic arch, what's going to happen is that ear will shift and start to correct and even out. Unilateral occipital flattening, you're going to have ipsilateral forehead bossing, contralateral forehead flattening, and contralateral occipital bossing. You can see here, it is a parallelogram shape, like I was explaining previously. There's no presence of synostosis of the cranial sutures. It's more prevalent in males, and 77% with right side plagiocephaly. That has not been studied, but it would make for an interesting study. 89% report to be supine sleepers since birth. And so once again, deformational plagiocephaly, we're taking the differences between the two diagonals at 30 degrees off midline. Our goal is constraining the growth in the elongated area and allowing growth into the area that is flattened. In this case, the A dimension here from front to back, you can see that it's shorter, and therefore that's the area that we want to grow and we want to contain the measurement showing the B measurement here as being longer. We want to initiate treatment over 9 millimeters. For deformational brachycephaly, like I said, what we're doing is we're taking the width divided by the length times 100. That gives us the index. Normal is 78 to 85. Brachycephaly is considered anything from 85 to 100. For us, anything from 85 to 90%. What we're going to do is we're going to go ahead and follow them along, but we're going to initiate treatment anything over 90%. So we consider mild anything under 90, moderate anything from 90 to 94, which is where we're going to treat, and 94 and above is considered severe. So when you have a combination of both plagiocephaly and brachycephaly, we call that deformational asymmetrical brachycephaly. It's a combination of both. And you can see here you have the width increased as well as the flattening on one side. Almost 100% of the time this is begins in utero, and then if they spend any time in the NICU, it's definitely increased and becomes more severe. But what you're going to have is bilateral occipital flattening with increased flattening on one side that crosses midline. Frontal asymmetry and or bossing may be present. And typically you're going to have some facial asymmetry present on this because the width and the plagiocephaly, both the combination, does present forehead bossing, anterior movement of the ear, and the cheek being anterior manipulated. We're going to initiate treatment for either one of the deformities, even if one's mild and the other's moderate. Whichever one is more severe, we take into consideration to begin treatment for. So the critical time to start is 4 to 6 months, like I was saying earlier. And the reason why is because that's when we're getting the most growth. The bone is thin at that point. It flows and is very easily manipulative within that time frame. But we want to get them before the bone starts to get thick. So 85% of the cranial growth occurs in the first 12 months of age. And this is what makes babies look so cute, is they have those small diminutive faces, and then you have this really, wide head, very cute. But as they get older and that face begins to grow, that cuteness, it doesn't completely go away, but it's just not quite the same as when they're little babies, as you all know. So when we look at orthotics and the different designs, I just want to point out that typically if you see a clear one like this one down here in the right corner that says plagiosaurus on it, that's typically used for post-operative treatment. And the reason why we want to use one that looks like that is because we typically want to be able to see in and see what the sutures are doing post-operatively. Plus, we typically want very good close contact and good suspension. And usually that's one that we'll use right after they've come out of surgery, so we can get that containment and protection on the head. But most of the time for positional deformities, you're going to see the polypropylene with Alliplast type helmet design, like all the other ones here, with the exception of this top one. And that's what you're going to see primarily in your clinic. They will have the top of them cut out, and the reason why is that allows them to open it a little bit easier, and it allows for a little bit more aeration and cooling. Okay, I want to emphasize this. This is very, very important. Insurance coverage, especially here in San Antonio, where we have a high degree of Medicaid patients, for positional deformities, and that being plagiocephaly, brachycephaly, and a combo, which is asymmetrical brachycephaly, most private insurances are going to cover that. It depends on severity and what is in their plan, but most of the time they're going to cover them. Medicaid does not cover positional deformities. The reason why is because they classify this as a cosmetic deformity, and it's not considered a medical necessity. I know a lot of times you'll have people say, "Oh no, we cover it. It's a covered device." It is not. I promise you. I am on the committee at the state of Texas with Diego Bernal, who is our representative for that movement to get it covered. It is not a covered deformity through Medicaid. We're hoping that it will at some point, but at this point it is not. Now, for craniosynostosis, which is where we require surgery and helmeting most of the time, both Medicaid and private insurance plans are going to cover this. And typically it's going to be for multiple helmets, but they consider this a medical necessity, and rightly so. And so that is a covered device. And you may want to know that. The principles of orthotic intervention and the biomechanics behind it, what we want to do, and we're not dealing with heads that typically look like this diagram over here. We really wanted to kind of show in a kind of drastic image what we're doing. But what we're trying to do, we just simply utilize head growth to grow into the shape of the helmet. We are not pushing on the head in any way, shape, or form to make it smaller. What we're doing is just allowing the bone to flow into the areas where there's space. In this particular area here, you can see where the eye and the cheek is. And what we want to do is we want the head to grow anteriorly so that it fills in that void left by that helmet. Same posterior here. What we want it to do is grow in the posterior aspect and create symmetrical shape. The helmet determines what the head shape is like. And so we're allowing space in the areas we want it to grow and creating a pathway for growth through symmetrical helmet design. Average treatment time, it's typically about 3 to 5 months. If we get a severe baby where you have a cephalic ratio that's over 100, we're probably looking at 6 to 8 months, or a plagiocephaly where we're looking at, 18 plus millimeters of asymmetry, we're looking at, 6 to 8 months. One of the biggest things that we deal with, and I know you all are familiar with this, is just compliance. If they're growing and they're out of the helmet, we're losing valuable time to be able to attain that correction. Once again, we're looking for total contact. We want to have a structured follow-up. We want to monitor cranial growth, like I said, with scans, so that we can overlay where the correction is occurring, doing manual measurements by using calipers or a tape measure, and we do ongoing adjustments. You can see here that we have about a ½ an inch of foam inside the helmet, and the reason for that is it provides a little bit of comfort, so it's not uncomfortable for the baby, but primarily it's so that we can, if say the baby's in the hospital and they're out of the helmet for say a month's period of time, and they come out of the hospital, but they put the helmet back on and it's really tight fitting, and we have to kind of readjust it. That ½ an inch globally within that helmet gives us the ability for us to grind out the foam so that we can get back on track into correction. What we're looking for in kind of the wearing guide is blanching or peak areas. You're going to have those in San Antonio or Houston or anywhere here in South Texas, because we're dealing with humidity. If you say you're in an area where it's a little bit more dry, you're not going to be dealing with so many skin issues because the skin the pores are a little bit more closed up. But what we recommend is using Aquaphor or Eucerin, wiping the helmet out. And the reason why, because we want to keep the yeast and the bacteria out of there so that we don't cause any skin infections. One of the bigger things that we're looking at here is we have a lot of heat rash. We require our patients to keep their house below 72 degrees here during the summertime, because the ambient temperature for a baby in a helmet will increase by about 4 degrees. So it's something to take into consideration. We encourage them to wear things like shorts and t-shirts, flowing clothing so that air movement can cause cooling over the body, because a lot of the heat rises through the head, and we want to alleviate that sweating as much as possible. Orthotic treatment usually ends about 12 to 14 months of age for patients. Once again, we really we don't encourage starting treatment after that time, primarily because the bone is so thick. The patients are just non-compliant. Babies are able to take the helmets off because they're very strong and can undo the strap, things of that nature. And it just makes for a really long, drawn-out treatment. and typically we like to start babies around 4 to 6 months of age. But typically it's about 3 to 4 months of treatment time for younger infants, and 4 to 6 months for patients that say would start at about 10 months of age if we decide to go down that route. Now, for post-operative treatment, we're looking anywhere from 2 to 18 months of age with multiple devices. And the reason why is because once they remove that bone, it takes time. We're not necessarily molding it that whole time. What we're doing is just waiting for that bone to fill in and create a bridge so that there's stability from the correction that was achieved from the surgical procedure. So how do we go about with this wearing schedule for these helmets? Typically, what we're going to do is the first day, we're going to, they're going to rotate 1 hour on, 1 hour off, 1 hour on, 1 hour off throughout the day. Not for nap times and not for nighttime. We want to skin check at each diaper change and wipe the sweat out. It typically takes about 2 weeks for these babies to get used to the heat of it. And primarily what we're doing with this break-in schedule is getting the foam to break in. Just for example, just like if you're going to go jogging, you'd want your shoes to be broken in. So they kind of take away some of the little anomalies, and there's no protruding areas from the skull that are pressing against the foam until it breaks in. And it helps us ensure that we're not getting breakdown from the sore, from the pressure and creating sores. So as you can see, as you move through, we just keep increasing the wear time. 2 hours on, 1 hour off, 4 hours on, 1 hour off, and we work our way up to 23 hours a day. It can either be a 5-day break-in schedule or 7 days. It just depends on the skin condition of the patient when we start and other things that need to be taken into consideration. Special considerations: hydrocephalus is a contraindication. We do screen for that here at our clinic at the Mark. For anything that is controlled, it is not a contraindication. We treat a lot of babies with hydrocephalus. We just want to make sure that the pediatrician and the neurosurgeon are on board for that treatment, so that they know that we're moving forward with it, and we want to make sure we keep our channels of communication in case fever, anything like that pops up, so that we don't run into any further complications. And we do a real consistent and frequent follow-ups with this population just to make sure that we are not causing any undue harm to the shunt, and to make sure that they're maintaining a good, healthy flow through that device. Osteogenesis imperfecta. Yes, I have treated that a few times, only under the strict guidance and oversight of the surgeon and the team that is behind this treatment for osteogenesis imperfecta. I don't recommend it because, as you know, the bones fracture very easily. It can be lethal. There's no known cure. And it's just, there's so many other things that we got to be considering at that point. But it has been done. It's just not very often. Other considerations: NICU babies, where you have mini tubes and, glasses, oxygen tube, feeding tubes. Like I said, nothing is cut and dried. This is very difficult to treat. You have to train the staff at the NICU and trying to keep everyone compliant and constant adjustments, things like that. It's just a very tricky, and it creates more undue kind of labor within the NICU, and they have other things that are more important. What we recommend is, if you have a baby in the NICU that you've rounded and seen and they have a head-shaped deformity, you can work with the therapist for repositioning, ensure that that's going on, and then contact us immediately after their discharge, and we'll get them in very quickly and make sure that we get that deformity looked at, and treated if need be. Once again, the treatment protocol is going to vary on age and severity. If cranial remolding treatment is recommended, what'll happen is we're going to order a scan. We'll take that scan. It needs to be very current. It's an FDA-approved device. So it's hypoallergenic, closed cell foam, latex free, all of that. So we have to follow by really stringent guidelines to make sure that these devices are not causing any undue harm. Once we've scanned them, we send it off to the lab to be fabricated. We're going to receive it back in about 1 to 1.5 weeks. We'll have them back. We'll fit them with the device, train them thoroughly on how to use it, how to don and doff it, skin conditions, temperatures, all the things that I spoke about earlier. And then we're going to have a follow-up to make sure that we're getting correction, compliance is achieved, all of those sorts of things about every 2 to 3 weeks. About every 6 to 8 weeks, what we're going to do is a comparison scan. This is important to make sure that we're tracking the progress. Plus, it's to make sure what it does mainly as well is it helps the parents to stay involved when they see that they're getting the correction, not only visually by looking at the patient's head, but by it being verified through the scan. What that does is it helps them to stay on board. Compliance, once again, is everything. We'll give them a copy of the scan so that they can take home and put it in their scrapbook, whatever, track it. And then we will also, we'll do a full discharge report upon completion. Every time we see a patient here at our clinic at UT, we send the pediatrician the notes that we've taken initially with copies of the scans, and upon discharge, we will also provide the final discharge notes to the pediatrician, just so it keeps everyone into the loop. We found it's good correspondence, and it's just good practice of care. So let's take a look at some of the outcomes for plagiocephaly. You can see here, this is just a 3D image. Our measurements are up there. We've taken them from a 14 millimeter asymmetry, which is considered severe. You can see the posterior flattening on the left there. And on the right is when they were done. They were down to about 4.8 millimeters. Remember, anything below 6 is normal. And so once we take them out of the helmet and they are rolling and turning and moving, what'll happen is this head shape will continue to shape naturally, so it looks like the parent's head, and it can be quite drastic, and the outcomes are very good with these devices. This is what the scan looks like. Once again, you can see we're able to overlay 3 separate scans here. So the red is the beginning, the blue is 2 or 3 scans into it, and the green on the outside here is the final scan. So it went from 14 to 7 to 4.8. And so this is what we'll give them so they can take it home with them. You can see we have indicators here, posterior right, anterior left, just so you can see how it's positioned on the scan itself. This is a before and after of asymmetrical brachycephaly. So remember, asymmetrical brachycephaly is the short head along with one corner or anterior corner and a posterior corner being flattened. In this particular case, the patient went from a cephalic ratio of 98.3 all the way down to 90.7. Anything within the 90 range, below 91.2 is within 2 deviations of the mean, so that's considered going to be normalized or mild. They went from 14.8 all the way down to 1.7 millimeters, which is spectacular. All right, let's move on to craniosynostosis. So craniosynostosis, as you know, and you all are feeling the soft spots soon after birth, is it'll present with typically no soft spot for sagittal patients, a raised or firm edge where the sutures close early and begin to kind of raise up and create kind of a wedge across the skull or multiple sutures. Slow growth or no growth in the baby's head size over time. There is no known cause, even though they think it can be hereditary. I've seen multiple babies from the same family come in. A CT or a CAT scan to verify. This requires surgery. If not treated, it's going to cause blindness, seizures, brain damage, just as a result of the intracavitary pressure. Typically, the way they're going to treat it, here in San Antonio, we do both the endoscopic or the open cranial vault procedure. I don't know if many of you know this, but UT San Antonio under Dr. David Jimenez, in the endoscopic procedure, he was one of the primary pioneers of it. So that's kind of our claim to fame here. And we see patients from all over the world here in our clinic at UT for endoscopic procedures. We are very experienced at it, have a staff of surgeons and plastics is involved, and we see quite a few patients, very good results. How prevalent is it? Of the craniosynostosis patients, approximately 60% or 1 in 2,000 to 2,500 births are where it's going to show up more prominently in male versus female. Unicoronal, only 16%, 1 in 10,000 live births, more prominent in females versus males. Metopic, 16% of the cases, 1 in 15,000, more prominent in males versus females. Bicoronal, 2%, more prominent in female versus male. And lambdoid, very, very rare. Out of all the patients I've seen over approximately 15 years of doing this, I've seen, probably about 10 cases. It's 1 in 33,000 is the incidence. It's more prominent in males versus females. So what does this look like? I think this description or this drawing here depicts it the best. Sagittal, which has a very low cephalic index. Remember, we take the width divided by the length multiplied by 100. A normal cephalic index is 78%. For a sagittal synostosis baby, they're going to have a scaphocephalic ratio that's going to be around 60 to 70%. Usually it hovers around 68% from what I've seen. Surgery is required. You're going to notice that there's going to be an anterior height or the apical rise in the forehead in the anterior portion, and it's going to slope down to the occiput and have more of a bullet kind of shape in the back. It's going to be wider in the forehead region, and it's going to be more narrow in the back. Metopic, if you see metopic, this is what it looks like. It's going to have more of you're going to have this real narrow aspect at the metopic suture. As a result of it fusing, the forehead does not grow wide and round out. And so you're going to get this pointed aspect. You're going to get slanted orbits. You're going to have a trigoncephaly shape, which is more like a triangle, and the ridging will be very prominent. It will run down to where the bridge comes into the nasium. You're going to notice the hypotailorism and just kind of a widening of the bridge of the nose just as a result of that suture being fused there. And as it drops down into the nasium, you're going to get this widening kind of here in the cilium, and it's going to create kind of a different look. These are quite difficult to treat because you have to hold the anterior and the posterior, specifically at the metopic suture where it's been corrected. Once it fills in, we need to get the lateral aspects to push out. So the treatment typically is around 10 to 12 months. Unicoronal, what you're going to notice is the fused area here is causing a bulging on the opposite side, and you'll notice that the eyelid will drop down. You'll have a drop in the orbit, and once that's released, what we do is we hold the area that's bossed, and we get the opposite side to fill in. These are rare, but we do see them, and they take a long time, and the outcome, it's marginal just because there's so many bones and corrugations in the face that need to be manipulated through treatment within the cranial device. So what that does is that makes it very difficult to treat. Treatment is very long, typically a year in these multiple devices, but rare. But one thing is, if you send them into our clinic, we provide any of our evaluations are free. So feel free to send them on over, and we always screen for that and make sure that that's something that we want to rule out at a very young age, hopefully before 4 months of age. So if we need to do endoscopic, we can do it at that time. Bicoronal, this is where you have the two coronal sutures are going to be fused. As a result, you'll typically get growth in the forehead where it moves anteriorly, and the head begins to widen just as a result of not being able to grow anteriorly based on those fusions. This is going to be common in syndromic patients. Typically, Cruzons, Aperts, any of those are going to present with this. And you can see, like I was saying, you kind of had this forward kind of sloughing of the forehead, shallow eye sockets, which are going to require plastics to go in and do an orbital advancement later on. But we'll start with doing hopefully endoscopic procedures so that we can cut away those fused sutures. And we want to hold there and get it to grow posteriorly so we can start getting that cephalic ratio to drop down. Lambdoid synostosis, extremely rare, but what you get is as it's fusing, it begins to grow in the areas where the sutures are freed up. So you start to get this torquing, and at the cranial vault here at the base, you start to get this kind of lateral movement over the top of the suture and a kind of a twisting look. It's very odd looking. Even below the suture, you'll get growth. So you start to get these really interesting measurements where you have everything growing kind of in a C shape around the suture that's fused. Very rarely, but occasionally you will get where both of the sutures have fused. This is going to happen in a syndromic patients where you have almost all the sutures can be fused. So you'll have bilateral lambdoid sutures that are fused, but that's very, very rare. Something to look out for is that in plagiocephaly, you're going to have a parallelogram, and the ear will be anterior on the side of the flattening. In synostotic patients, like lambdoid, you're going to have the ear moving posterior on the same side as the flattening. So we have a saying that if the ear is near the deformity, stay clear. That's when you'll want to send off for further evaluation. So let's talk a little bit about the difference between cranial vault reconstruction versus endoscopic. Open cranial vault is done in patients that are older. We're typically looking, like I said earlier, any patients over 6 months of age. They'll typically wait and do that surgery at about 10 months of age. They'll do a zigzag pattern, cut ear to ear, and do and pull it apart and make sure that they make the incisions based on that. This one here is a sagittal, and you can see what they did is they come across the top, cut out the suture that is fused, and then they come down and make little cuts along the edge so that as the brain kind of, once they sew them back up and the brain kind of relaxes and the bone opens up a little bit, it presents with a more standardized shape. We typically are not going to helmet for patients with cranial vault reconstruction. We like to see them for endoscopic if we can, because the outcomes are just so much better. Now for endoscopic, what they're going to do is they're going to put their camera, they're typically going to make a couple slits, one anterior, one posterior for sagittal, and depending on what sutures are fused, depends on where they make the cuts, but this is kind of the primary way that they're going to go in and enter in. They're going to go in and make all their cuts, incisions, and remove the bone with cameras and emulsify the bone. Now they have techniques where they can use drills and vacuums at the same time and pull that bone out just by emulsifying it without actually having to clip it. But what we want to see them, the reason why I want to see them, before 4 months of age is because that bone is so thin they can actually clip it out, and it doesn't require or it doesn't result in a lot of bruising and things like that or swelling. But there's very little infection. Typically, it's going to be a one-night stay in the hospital after this procedure, and it only, it's very short, hour, maybe hour and a half at the most. This shows a sagittal patient. You can see here where the incisions were made, anterior at the fontanelle and posterior at the posterior fontanelle junction there. Here's the bone they took out. What they'll typically do for endoscopic is you can see these pie cuts, and they'll make little barrel staves, which are little wedges in there as well. And then they'll come in front of the anterior fontanelle to remove any of that sagittal suture going up into the metopic suture, just to make sure that as this head, as the bones kind of relax there, they open up so that the brain can kind of settle in there and spread the head shape out a little bit and give them a more normalized cephalic ratio. Remember, these patients start at around 60 after surgery, 60, 65, 68 for pre-op cephalic index proportion. By the time they're done with the surgery, they end up around 73 to 75, and then we want to move them up from there so that we can get that cephalic ratio to increase a little bit. So clinical outcomes you can see here. Asymmetrical brachycephaly, like I went over before, this just shows you what it looks like from an actual head. Flattening here, anterior and posterior widening of the head. Here it's elongated with a nice symmetrical head shape and rounded in the back and in the forehead. This is post-operative for metopic. You can see here, real pointed. They came through, made the incision here, released the metopic suture. They were helmeted. It rounded out nicely, and this is 2 years after the surgery. You can see how nice and rounded out that forehead is. That's it, folks. Thank you very much. Any questions?
Jim, we do have a question in the chat box. I don't know if you can see it, but I can read it for you from Dr. Jones. Since Medicare does not cover treatment for positional plagiocephaly, can we presume long-term outcomes with control groups have shown demonstrable significant cosmetic difference between the treatment and non-treatment groups? While measurements are likely significant differences, are cosmetic differences significant? I'm particularly interested in outcomes in patients in the moderate group.
In the moderate group, so I mean, if we get a patient before 4 months of age, we're going to reposition them. And the reason why is because they don't have the neck strength to hold up the helmet. That's partially why we like to see them at 4 months of age. But we're going to follow them along. If they're moderate and we follow them along for 4 to 6 weeks and we see that there is correction, we're going to keep following them. If we see that it stays where it's at and does not correct or gets worse, because time is not on our side, we're going to go ahead and begin treatment, because once that bone starts to thicken up and the growth starts to slow down 6, 8, 10 months, then we're losing time, and our window of time to actually get that correction is closing.
The question was, is there any cosmetic difference between treated and non-treated groups with positional plagiocephaly in moderate group?
Yes, there is. Yeah, absolutely there is. And, like I was showing you on those outcomes, I mean, it's very rounded out. You don't have that oblique angle. You'll notice it a lot if you go to put on, say, a bike helmet for an untreated patient. That helmet wants to turn into the flattening. And so what it does is the helmet fits in an oblique fashion. Or if their head is really wide, the helmet wants to tip because it's only grasping onto the areas that are wide, like in brachycephaly, which means short head, so it tips. If a helmet in this instance doesn't work appropriately or doesn't fit appropriately, it doesn't work effectively. And so that's what we see. For the trained eye, absolutely, you can see the difference. And we always give parents the first choice. If you can see the difference, then do it. If you can't see the difference, then make that decision as to whether it's something that you want to pursue. I hope that answered your question.
Jim, the next question is, what is the sensitivity of plain X-ray for plain skull X-ray for craniosynostosis?
What is the pain?
Plain X-ray, the radiograph, as compared to CT or MRI.
Yeah, we want to go CT or MRI. Low exposure CT is the best way because oftentimes the X-rays won't reveal it as clearly, and the last thing we want to do is go in and do a surgery where it's not required. But here at UT, we do a low exposure CT.
What's the sensitivity? Do you know for the plain radiograph for detecting craniosynostosis?
What is the? I'm sorry.
What is the sensitivity? How sensitive is it to just get a normal radiograph?
I don't know.
You don't know. Okay.
Yeah, I don't know. I just know it's not the standard to be able to diagnose it.
Okay. Any other questions, comments for Jim? I don't see anything. So Professor Brookshire, thank you very much for your wonderful presentation on the skull deformities. I thank you all for attending this morning's grand round. Again, as I said earlier, please complete the evaluation. It's important for me to give feedback to the speaker. And we should join the faculty meeting in 2 minutes. So thank you all. Have a wonderful Friday and a wonderful weekend.
Thank you all.